Okay, we'll do it again. Welcome to session 4, completely on the IVs. You can watch the YouTubes on the starting of IVs and the hanging of piggybacks and so forth, plus this YouTube, which is session 4. Go to the agenda, page 31, and to the briefs, page 12. And I'll just start at the beginning, and if you just know it so well, just tune out and think about your grocery list or something like that. The first thing, when you get a bag to hang, and this one's already been spiked, just hang it. The company says go on and pull the tag. It's not going to pour out because it hasn't been punctured. So hang it up, and the company asks that you hang them up. Some people hold them and spike them in their hand, and the company says please don't do it because it's so easy to go through the neck. So hang it up and pull your tag. Open your tubing, your bag of tubing, and make it a rule that anytime you open tubing, the very first thing you do is clamp. Usually the big white clamp. Go on and clamp it, because as soon as you spike your bag, the fluid's going to flow if you haven't put your clamp on. So any tube, I say any tube, there's one exception, an extension doesn't need to be clamped because you're putting it on something that's already been clamped. So an extension tubing, there's just extending, doesn't need to be always clamped. With piggyback tubings, primary tubings, always clamp before you spike. So you take the tubing, clamp it, and it's ready to spike the bag. Hold the neck of the bag and between your fingers kind of saw it in. Are you there? Squeeze the chamber. If fluid comes down, you've made the puncture. Now, when you've got fluid in the chamber, you're ready to get the air out of the tubing. So you simply, and I always say, I don't know whether I did on the video, but do it with dignity. Hold your end of your tubing, dry tubing, in your finger, and with your dominant, if you're dominant right-handed, unclamp what you clamped and let it flow. People look for waste cans so it'll flow in. I tell them no, because you're going to not need a waste can, because you're not going to waste that much fluid. Unclamp, wait till it comes down here. As soon as it does, clamp with your fingernail, and then clamp with the white clamp or the big clamp. And that way, this stops it, and it's not just pouring out, and your hands are wet, and you're slippery, and all. It's some dignity to it. Now it's been flushed and ready for insertion into the IV. I just wanted to point out that the tubing has the disc, the white disc, that keeps anything from coming up into the bag. And that's all the purpose is. So you'll never be able to push up anything past there. If you were here and wanted to push it to the bag, you're just going to have to put it in the bag at the place they have allowed it. All right. Now, so this particular IV has been spiked and purged or flushed, and it's ready to go in the machine. They're not universal, but they're all primary infusions, secondary infusions, and you do not have to be a master of this after today. Whatever facility you may ever work in, or a home, a little reading of directions is enough to learn. But the tubing is made to fit the tubing that has been bought for it. So let's say that this tubing, and I think this one will work, it will fit in this pump and slides in blue to blue. Usually all in the medical community, blue to blue works. And then close it. Oh, real important, and you probably remember from the video, there is the little air V. And you can put the tubing right here and the door will shut, but this sees air, so it keeps beeping, air, 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 because it sees air. But the door's shut and you're right here, but it sees air. So do what it says. It's telling you air, so take it out. Make sure you have used your fingernail to push it into that V. You just push it into the V and then close the door. You turn the machine on. It may beep at us and we'll have to turn it off. And it gives you directions. Is this, have you used this before? They ask, is it new patient? Is it an adult patient? And you just answer those questions. And certainly the video doesn't catch it. It says new patient, and I'll say no or yes. Doesn't matter. Usually everybody says no. And then adult, yes. And then this, you always see, we may have room for another IV over here. And these come off, and you can have one or two more if they're at probably the unit where they've got several medications going, maybe different ports. So this one is the one we're using. So you always tell the pump which one you're using by just pushing channel. And so that's the one we're using. And it comes up and asks you some questions. This hospital always does just basic. And so I'm going to push basic, and it says primary rate. And primary would be what the physician ordered, how fast this IV should go. So we'll say, I'm just going to do it 10 so I'm going to push rate, and remember it's milliliters an hour. The machine is always milliliters an hour. So I'm going to put 10, and then volume to be infused, not quite dry. Let's say this bag is 250. I'm going to make it 200. So volume to be infused, VTIB is 200. I didn't want to do it all, and I'm going to start it. I didn't want to do it, there's a start button. I didn't want to do it all. Now it's unhappy, and it's unhappy because it always needs to be green. It's unhappy because I had that clamped. I hope that's the only reason it's unhappy. I'm going to restart. Something else is going on, and it's probably because it's got air and everything else. Because this tubing is not regular tubing. I mean, it's not clear. So this tells you something's going on with this. You've got to rectify it. You take it out. You see. Now, when you open the door, I opened the door, it pulled that forward and clamped it. In the old days, if you open the door, you better have it clamped down here. Not anymore. As soon as you open the door, it clamped. And so then you look and see and think, well, now, is it patent? So you'll unclamp it by just pushing it. Now it's open, and it's moving real good. I'll try it again. Put it in, put it through the V, close it, and restart. Yeah, it's green. It's happy now. I think I'll get a waste can and let it go in the waste can since it's actually happy. Now, notice it's got a port up here. They've got a port down here for us to add medicines to. So the physician came through and asked that we give a piggyback of antibiotic. So You open the tubing for secondary, which is just smaller. It's just a smaller bag of tubing. Open it, first thing you do is clamp. We know that. And I had so in the package of tubing for secondary was a bracket and the tubing. So I clamped the tubing, and then I'm going to hang my piggyback bag, checking it, and put it up. While you're up here, pull the tag. Still, it doesn't come out because it hasn't been punctured yet. And then take your tubing and do the same thing we did a minute ago. Hold your neck, sew it in. I clamped it, remember? So it's not dropping, it's got a cover on it, and I spike it. Now the tubing is dry. Now everybody has a little different way, but basically they're same. We just don't want a tube of air. Now the way I just did it, I spiked it, and it's got air because I clamped it. It's got air. So I am going to wipe the port up here 15 seconds, unless you have the Brovantic, which is a different swab that just allows you to do it once. But if it's your alcohol and you don't have any Provantics that are on the floor, they're in a different envelope, then do it 15 seconds. And I think we've gone over, but I'll pass some of these around. It's got a spring there, so it has no cap. That's the reason I want you to be sure and wipe good the top, because as soon as I put this tubing, let's see, okay, I spiked it, it's all dry, I clean this, I take the end and put it in that, and you have to push that spring in the middle down and screw it on. Now I've got a whole tube of air, so you've got to keep seeing yourself. I've got to get the air out, But take this, it came in that package as well, and the main bag has to be lower. I'm going to, if you can leave it low like this, I'm going to do it. It has to, even though you're on a pump, it still needs the gravity help. So I've got this dry tubing, and the way I do is lower it below the main bag and unclamp. And this is the only place I'm interested in bubbles, because they're in the tube and I want them gone. So I take the clamp and unclamp, and the fluid from the main line goes in and pushes air up. Not doing it so good here because it's been used. But, and if it isn't doing it, sometimes I can raise it and still not doing it. But it will get the air, it'll backtrack the air out of the tubing. And when bubbles quit in here, they may go on here for a while because it's pushing air. But when bubbles quit here and the level of the fluid comes up, just raise it up. Don't stand here and try to clamp it, because by that time it's gone completely up into here and up into here. That doesn't hurt anything, but it just means I've got to be able to see my drip. So I push it back down here, and that's a lot of air. So I do it all again. Lower, lower. Oh, it's doing it now. The air's coming up. Raise it up rather than clamp it. Why do you not want to clamp it? Because so many times people forget that they clamped it, and they start the piggyback, and it's not going to run if it's clamped. Won't it scream at me? It will if the main line is clamped, but it won't with the piggyback. It just delivers what you put on the piggyback directions, it just delivers it from the main line because you've got the piggyback clamped. So the best way is to don't clamp the piggyback back. Just raise it up. It stops as soon as you've gotten it above the level of the main bag. Now, I've got my main bag, I've got my piggyback, everything's primed. We put it in the patient. It's been going at 10 an hour, the main line was, but now we need to give the piggyback. And how fast does the piggyback go? Well, it's probably on your medication administration record. Deliver this at 200 an hour, 200, and we know it's 200. Yeah, it'll always tell you the milliliters an hour. Sometimes the bag comes up and the piggyback back and tells you how fast to do it. But it's provided for you. Let's say that our bag said deliver it in 100 an hour. It's 100 bag. So 100, it's 100 milliliter bag and it wanted in 100. So always the pump we're using, remember, when you come to a pump, you have to tell the pump which pump I'm going to use. And we're using this one. And it comes up, and right down here, it says secondary. And we go to secondary, and if you're at Centennial, it lists some medicines, Keflex, different ones that are a lot of times used as secondaries. Here, they just want you to go to basic, secondary, and then basic, and here's secondary, rate, volume to be infused. It's 100 an hour, so I push rate, which is 100, volume to be infused, and I don't know why that, let me do it again, 100, volume to be infused is the volume to be infused, and then they want a little more because they want it drained. They want this dry because we're going to use it for, let me put in 110 and start it. Starts right there. And I tell students, don't leave till you see the word secondary scrolling across here and dripping, and it's doing it. Now, when it's finished in an hour, because if it's going 100 milliliters an hour, volume to be infused 100, it's going to be an hour. And when it's through, it just beeps, you can hear it in the hall, and goes back to the main line. You don't have to do it to put it back. The keeping a record of it is above the pump, so it's making a record. You don't have to keep separate your secondary amount. Now, let's say it's through, it's 6 hours later. They want us to give this every 6 hours. So the main line, I'm going to go back here and go to primary and start. Stop secondary, yes. Okay, now, so it finished. This is a dry bag, secondary bag. And it was through in an hour, but we don't do anything about that. It stays till 5 more hours when we hang another one. And the tubing, which I didn't do, and I should have, put on there when it needs to be changed. 4 days is about what they're saying now. Some hospitals say 3. So my floor does it every 3. We do it every Tuesday and every Friday. So 1 week it goes 4 days and 1 week it goes 3 days. And so if it always should have a tag right here that says change Tuesday or change Friday. And that takes care of that. You don't have to put one on your piggyback because the idea is that they're together, piggybacking. So 6 hours have passed, and it's time to hang another one. So I get another piggyback, What if it's not the same drug? Go to your computer and see if it's compatible with what was here, because they're going to touch in here. I thought you did. It took 110, so it took most of the fluid from my first bag, but it still might touch and some residue. Are they compatible? So look them up if you don't know. Most of them are. The ones that aren't, you kind of get a neon alert if it's only never mix with so-and-so. So here's our new one, piggyback. And the thing I want you to do before you do another thing when you walk in the room is clamp the piggyback. Because when I bring the piggyback down, it's even with my main bag and it's filling up. That empty bag is filling up with IV fluid because I didn't clamp it. So always, before you do anything to your empty little bag, you clamp it. I just tell students, lay it up there. Hang the new bag up, and then take this one and spike your new bag. Now, we have fluid in here, but that last bag took it with 110, took it down to here. I need to get air out. I do the same thing I did before. I lower, I unclamp, I wait till the bubbles quit, and too much. But when I did that, I have an air pocket, so I do it, and then they come up, and when the level starts coming without bubbles, don't look at the bag, it's going to be bubbles there all the time. Raise it, stops. And this one wanted 50 an hour. It's a 100 milliliter bag. So I do the pump I'm doing. I go to secondary, right there. I go to basic. And my secondary, they said they wanted, what did I tell you, 50 an hour? So I'm going to go 50 milliliters an hour. Volume to be infused, a lot of my students will say 50. Well, no, this is 100 bags, so it's got to be 110. So 110, and then start it. Secondary, is it dripping? It's going to yell at us because it's not. So I use this for 4 days or 3 days, same as the main line IV. Now I'm just gonna, for practical purposes, go back to primary and do you stop secondary? Yes. Now, let's say that it is this is dry. My main line has run out and I need to change my main bag. Well, this tubing's fine, 4 days. And if you're a great nurse, you put a little tag on here that said when you hung it. Because like last Wednesday, a student had, it wasn't on there, but when we looked at the MAR, it was hung at 4 o'clock in the afternoon, the afternoon before. So I told her, it was just going 40 an hour. So I said, you may still have some in it, but it still needs to be tossed at 4 o'clock this afternoon, 24 hours, because of Pseudomonas. Everything needs to be thrown out in 24 hours because of the water bug. Even though it's sterile, it just grows the water bug. Your peroxide at the side of the bed is 24 hours. They don't want, they even say your pitcher of water that you may keep at home, that is 24 hours, or a glass of water you have out on the counter. If it's been 24, Pseudomonas has probably gotten in it. You're strong enough that your body can ward that off, but sick people can't as well. They say Pseudomonas is on our shower heads in these bathrooms because it lives in water, it lives in moisture, and there's no way we can be on top of it. You and I do all right because our resistance is stronger. So we can at least change things every 24. So this is run dry, and I need to change my main line. Don't need to change my tubing. It's going to be 4 days. So I get another bag of whatever, and pretend it doesn't have a cord. And here's my bag. Now this is the part I want you to watch real carefully and do, and it's on the video. My only rule with changing a mainline IV is keep the chamber upright. Don't do that, because the chamber, why? Because it got an air pocket. Well, we did fine with an air pocket with piggyback, but you don't do that well with mainline. You have to get it out of a port, aspirate. Some people take it apart and run it in that waste can. That's opening your line. I don't like that particularly. So this, if you'll always keep it upright, so that means take it down, wad the part in your hand, and I can do anything as long as I keep it upright. High, low, over. Now my new bag, I'm going to hang it. Of course, I hang it on my bracket. I pull, look, I've still got this in my hand. I pull the tag. Nothing's coming, that's fine. Now take this. I thought you said it was dry. Well, it has a little left, because I usually change it with a little bit left. I just turn it over so it doesn't drip all over, but I'm keeping this upright. You've got to keep it upright or it gets an air pocket. So then I take it apart and spike my new bag. And supposedly no air escapes into the tubing when you do that. So my new bag is hanging on the bracket, and the only thing I need to do is tell the pump that I didn't change my rate, but pump you're using and go, rate's not any different, but my volume to be infused is the new amount. And so don't do this whole 1,000, do 800 or 900. Well, that's probably said about something. Okay, so that's the changing of the bags, primary bag, changing of the piggy bag. Just remember the biggest things. See what it's saying. Oh. Clamp the piggyback so you can lay it down. This one, I don't mind up and down over, because we're going to lower to get air out. You just can't lower the main line and get a backup. The only reason we can with the secondary is that the backup of the main line goes into the secondary. This is on its own as far as air. And like I said, it means you've got to aspirate fluid out with air or run it in the waste can, which I don't like because it's opening your system. Now, with that being said, and the main thing with this is keeping this upright and not ever lay it down. Other one we can lay down all we want to because we're on a backtrack. Now, I think I want to go to giving of blood. And so the physician decides that they want to give blood to this patient. They've got all this. Now, blood does not need to run with anything but normal saline, 0.9. Remember, that's 0.9%. It's not even 1% salt. It's 0.9% salt. So that's our secretions. So that's what blood is compatible with, is 0.9 and only 0.9. So this happens to be, well, this is sodium chloride, our IV. But if you've got a triple line, central line that's got other ports, they do let us give blood as well as what's running. But let's say it's peripheral and we only have one port. We cannot run this IV with our blood. And blood, okay, turn in your briefs, you're on page 12. I think it's 13 that I wanted blood given. Do y'all see the administration of blood? What did I do? I know it's here. Push. I don't see it. Maybe we'll find it in a minute.
Page 5 and 6.
Huh?
5 and 6.
Page what?
5.
5, thank you.
Yeah.
So in the briefs, go to page 5 and you see blood administration. That whole page is blood. So briefs and you can read there. PCV, remember we said packed cell volume is like hematocrit. And I don't want to mess them up for you. So, the blood tubing is wide. And that's what it says there. So here's your blood tubing. So blood will be in one, and you already know what's going to be in the other, normal saline. And so you've got to get ready. Why are they doing it? And I told you, I think the other day, they're doing less giving blood, not in the emergency room. They're still giving it. They're still giving it in OR. We still give it some, but I don't give nearly the blood I used to up here, because the blood marrow needs to be busy. And you give beautiful, fluffy blood, the bone marrow rests. Whew, been working myself to death. And when it does that, it's hard to kick it back up, and rev it back up. So they'd rather not give the bone marrow a rest and have it keep working to produce cells, because that's what it's doing, the 3 cells that it's producing. So when the hematocrit is so low, and what does it say on there, 22 or 23? What's it say, y'all?
23 or 24.
How much? 23, 24. Mm-hmm. When the hematocrit reaches that, we want 40. And so when it's reaching 22, 23, we're getting worried, because that's got to take red cells and oxygen to our biggest muscle. And so we really need these muscles, but the biggest of all needs it. And so we've got to protect the heart and get good oxygen, and red cells are what carry that oxygen. So at 23, they kind of want a transfusion. So it may be 1, it may be 2. Sometimes it's 4 if it's really low. So we're going to say the physician wants 2 units and says that. What's it going to boot it to? If you and I had 2 units, they say it will boot us up about 5 points for each unit. So if I have a 23, it's going to boot me to 33. And it's an okay hematocrit. Most people on this round, they're running with a 30 in the 30s. Now, did you notice in your briefs on blood transfusions that you cannot, I think we've already said, you cannot give blood under 38. They'll let you give blood at 38, but if it hits 37, you cannot give blood. And so, on the church parking van, you go out and give blood on. So, this person has a low hematocrit, and we need to give it. They have an order, give 2 units, transfuse with 2 units. Maybe even type and cross, which means we've got to get some blood to do a type and cross match. So it's been done, everything's fine. The blood is here. They called us to tell us the blood's here. You can give it anytime you want to. So let's go on and get it ready to give. So we get our saline and get our tubing. And you know when we open the package, what's the first thing on this Y connector we're going to do is clamp. So open the package and clamp your big white clamp. And I like to go on and clamp the wings. Clamp here, clamp here. Now I have that on there, so don't watch it. So there's my Y, and I hang up my saline. This is still running. I've got to do something with, he's getting this antibiotic. And if you see blood, we don't want it to be out of the bank longer than 4 hours, and that's travel time. And so it takes it a good 30 minutes to finally get it ordered and up. So we know we've got 3 more hours, or 3.5 hours, and we just, you can see, I don't know whether, I think I wrote the rate. Let me just tell you, in the briefs, or the briefs, it tells you to start it at 60, I think it does, the rate. It's called a transplant. You're getting another person's organ, which is their blood. So we need to be very careful and prudent in giving blood. So we hang, we're not ready yet, but I'm going to hang my saline bag over here. We're going to do this probably on this pump, the other side. And so I'm going to hang my saline. And of course, it's not going anywhere because I'm clamped. And so there's my saline. I pull my little tag, spike it. Nothing's going anywhere because I'm clamped. So now I am going to open one side. Just talk to yourself. It's just common sense. I want all the air out of this tubing. So I'm going to open here. It'll come a little, but I need to help it. Now, do you understand I'm still clamped over here? So I just keep squeezing, 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 because it's going to fill my chamber. But do you recognize I have a filter in here that I didn't over here? See, that didn't have a filter. This one does because it's blood. So I just have to keep pushing. And I want the level above the filter. Now you'll walk in somebody getting blood, say you go visit somebody, and the blood level, the level of the saline's halfway. Well, don't call the head nurse and all that. You just go over there and squeeze it and get it above the level. In blood bank, I don't know why they don't push it more. Blood bank is who told me. The blood bank says it needs to hit saline, not plastic. The red cells, some of them may be almost 4 months old, and they'll break because they're fragile, they're almost dead. And you'll save their life if you let them hit saline. But a lot of people don't know that. So don't go make an issue. You just go over and squeeze it and keep visiting. And squeeze it above the filter. Okay, I've got it above the filter. I'm going to go on and flush this side. A lot of nurses don't, but the blood kind of sticks to the side. I just rather, so what I do, this is covered, open this side, and do you understand that's only where it can go? So it's common sense. It can't go lower. I was clamped when I opened my package. So here's what we do. As soon as it's up there, clamp it. All right, it's clamped. Now I'm ready to get the air out of the bottom part. And because I've got my fluid up to the level, I'm going to do my dignified flush, which is hold my fingernail at the end, unclamp here, and when it reaches there, clamp with my finger and clamp here. It's reached it. That's great. Now, I'm going to put it in the pump, that we're gonna use, it's capped. So I put it in the pump the same old way, and go through the little V, make sure it's there, and now I've got to put this. I can, because this was saline, I could find this port, what this was in the patient. I could wipe it good, take this blood set, put it here, and turn this pump off. I think I'll clamp it. I like to carry this clamp all the way down to the port that I clamped. This is on the main line of the piggyback antibiotic. And I like to clamp it. That way, when blood comes in here, it doesn't back up into the main line. And I'm going to have to turn this one on. And I need to go on and do, so now if I didn't put it in the port, what would I have done? Well, you can always take it off from the patient and put the blood set into the patient. It's just I don't have to open my port if I do it this way, because this is in the patient. I don't think it was on film. I just take this and put it, this is the blood set, into the patient. But I can use this, bring my clamp down, turn this pump off. I want to turn this one on. So I'm going to do basic for this one. And I'm going to tell you, I'm going to turn this one off because we do not need the antibiotic going with our blood. You say, well, the sodium chloride would be all right. It would, but it probably would overload them to give both. So I turn that one off because I don't want it to run. My blood set is on the port and this is in the patient. Or if I took this off of the patient, the blood set goes in the patient. Now, I'm ready to, thought that would,
You turn completely off.
huh?
You turn completely off.
I turned it off, but I thought that one stayed on. This side, yeah, it's back on. I like to make sure it's on before I turn the other one off because we got to do what we're doing now. So, I got to order my blood. And so, I want to get this started because when I come in, we're going to put the blood up here. You notice I didn't do my volume infused or anything. I could have done it then, but I think I'm going to do it at 3 o'clock this afternoon and do them both. So, new patient, no. Adult, yes. And this is the pump I'm using now. And basic, this hospital. Primary, the physician, now I'm going to tell you this, and your agenda doesn't share this part, but I'm telling you, you can put anything you want to in here, and I'm going to put, I may have it in there, 30. That's an hour, 30 milliliters an hour. Let me put it rate. I just came up with that. You can do any number you want to, but that's not a lot, and surely my blood will be here in an hour, which it will. Now it's running. 30 milliliters an hour, 30 volume to be infused, that's an hour for me to get blood up here on the floor. And nobody told me, I just wanted to get it going, and I didn't want a real lot of fluid. The blood arrived, and it needs to be checked. And so, this was packed red cells and air in the line. And if that happens, of course it would, because I take it out, make sure it's through the V, sometimes you look, oh, it was a little bubble. Just put it back in through the V, I think, and restart it. And I think it's not going to like it. Anyway, because I think there's air in that tubing. So take your blood, find another licensed person to read every fact known to man on this blood. The unit number, the donor number, etc., etc. Anymore, I don't know whether if you ever gave blood, we took a sticker. They don't do it anymore because in medical records they fall off. So it's all written. So this blood looks perfect. Great. So I'm ready to hang it. And I didn't run 30, but it doesn't matter. I think I will. There's a button here, volume infused, and it's what I do my I&O with. If it were 2 to 3 this afternoon, we're still on the old-timey 7 to 3, 3 to 11, 11 to 7. So it's 2 to 3, you do your I&O, and so you push the volume infused. Not volume to be infused, volume infused, and make sure it's clear, which it is. And if we want to do however much the B pump was, we can do that and clear it. And then go to the main screen and it's ready again. This isn't happy because it's got air, but now I've got my blood, we've checked it. I think we're ready to hang it. So a licensed person was with me. I put gloves on and just because any blood product you need to handle with gloves. So they don't have to be sterile, but you do need to do it. And so hang your blood up, and they come, you just have to investigate. Sometimes they're like Ziploc. Sometimes you just look. You've got 2 identical, it doesn't matter which you use, but whatever you do, pull it. It's not going to pour out on you. It won't. Take your Y. Oh, that was on the blood. That's part of the blood. Here's your Y that we've already primed, so it's not dry. And hold your neck, because if you puncture that, blood pours out. So go straight up, and you're not sure if you've punctured or not, but here's where you just do thinking. If you open that side, I promise you it'll shoot. Do you know we never close this side? It'll and puts blood up there, and you catch it real quick and clamp it off, because everybody sees what you did. So just don't do anything till you think it out. So I spiked it, but don't bring your hand down and unclamp. Come over here and clamp your clamp your saline, then open it, and then squeeze. Oh, it's not coming. Well, it means I didn't have it quite up enough. So push it up a little, squeeze, there it comes. But it's coming just at my 30. Now here's where it's not in your, and I'm going to just do that for a minute. I need to change. Now here's where I want you to listen with common sense. The tubing to the patient is about 20 milliliters. And so I'm going to, I could leave it at 30, about, we'll say 15's gone in, but that's a slow process, and I only have total 4 hours to get this in the patient. So what I do that isn't on there, because it's too hard to explain to generic students, I think you all can understand. If this is milliliters an hour, I want it to go fast with the fluid that isn't blood. I don't want it to take an hour just to get to the patient. And the tubing is about 20 milliliters. So if I put it on 30, that's almost an hour just for the blood to get to the patient. Do you follow? So I'm going to say, I'm going to put it at 200 my rate. So I push that. Primary rate 200. Volume to be infused 20. Just the length of the tubing. So that's pushing it fast, but it's going to quit when the blood gets to the patient. So I put 20 and start it. Now it's going fast. It's going to really beep because it's air. So it's going fast just to get to them. During that time that it's going, that's when I might vitalize them, take their vital signs, fill out some of the paperwork when I started it. You stay right at the bedside. It's not going to take long for that. But see, that 20 milliliters is just saline. And it's going to beep at me when it's delivered, the 20 milliliters. So let's say, well, I can see blood's all in the tubing. And it beeps. So I can see it's right at the patient. Now I'm ready to go by what your, doesn't it say 60? Mm-hmm. I'm going to start it at 60. I just left out that part, but I think you understand. I mean, there's nothing wrong with running it slow, but just know you've got to be through this in about 3.5 hours. So I just think it's easier to shoot in and get it going. Now we're ready to give blood. So the rate is going to be, so the pump I'm using, right here, pump I'm using, and the rate now will be 60 because we're giving this patient a foreign substance. Now I'm going to put 300, and I'm going to tell you why. Isn't that what your thing says there too? And then I'm going to start it. So I've got it at 60, which is slow. And that's pretty universal to start blood at 60. Volume to be in 300. Did I see 300 on there? No, I didn't. You can look till the cows come home. You're not going to find 300. What you do know, what it says to you is, this is from, now this one does say 300, but that's rare. This is just a simulated blood. If you look at it, it says taken from 500 milliliters, which is a unit of blood. And so it depends on the hematocrit of the donor, how many red cells I've got. Now, if it's whole blood, it's 500. But whole blood's only given in the ER and the OR. Blood on the units is red cells. And we hadn't gone over the hematology yet, but you know we have platelets, white cells, and red cells. And red cells, if we give them all, it's whole blood. If we just give red, which so often flowers only need red, we can give you the fluid. We just need the red cells. So often it says packed red blood cells, and you're just giving red blood cells, but it came from 500 a unit. They centrifuged and came up with however many cells the donor had. If the donor had a hematocrit of 50, then we probably have about 350 to 380 milliliters of red cells. We do know that if you have a 38 hematocrit, you can give blood, but it'll probably only equal about 250. So the rule is that red blood cells are either 250 to about 350. So I always put 300. Volume to be infused, 300. So we run it for 60 milliliters an hour for 15 minutes. And that is enough. And of course, tell the patient before you don't leave. I usually just go out in the hall and do something close and tell them, you know, it's risky because you tell them, I've used the word strange. What do you mean strange? If you feel different, what do you mean different? You know, it scares them. But you got to warn them. So you just say, if you feel any differently than you do right now, just buzz me and let me talk with you about it. And so when do we stop it? When does it scare us that we're giving this person somebody else's blood, which is organ transplant. And it scares us if they can't breathe good. Now we stop it for that. And we stop it for whelps. Big old blisters have come up. I think you know to do that. For pain, chest pain, of course. And those are things I think you'd know to do. But we do not stop it for flushing. We do not stop it for elevated temp. Praise the Lord, the body's trying its best to get rid of a foreign substance. We're proud of it. I'm sorry we're working it so hard, but we're awfully proud that the body's fighting it. On my floor, for mostly because everybody's compromised, we usually do a pre-op of Tylenol to cut down any fever, and maybe even some Benadryl to cut down reaction. And between the units, we might give Lasix to cut down on the load. Now, okay, 15 minutes are over. I've come back in. Are you fine? Yes, fine. They're a little flushed. And I might take their temperature, but we're not going to stop it for an elevated temp. So I'm ready now to get down to business. And I don't know, we can go up to 180 milliliters an hour. I usually like to go 140, 150. Right, so I'm going to change my rate from 60 to 150. And I'm going to leave volume to be infused. Just leave what it was. I put it in at 300 because that's 250 to 350. And that's what they say. If it's 250, probably you had a 38 hematocrit. 350, you probably had a good 40 or more. And sometimes you put it on 300, and when it starts beeping, you go in the room and you've still got some blood, which means that donor had more red cells than a 40. And it's great. Just give that to them. Just up your volume to be infused, another 50. So I vitalized them when that 20 was going in at 200, that 20, I took their vital signs. After 15 minutes, I want to do vital signs again, just before I booted it up. And I don't have to now get vital signs anymore till the end. Used to, it was 15 minutes, every 15 for an hour. And I don't know what they're doing at Vanderbilt or RE, do you? If they're doing it more often. But for the most part, do that initial 15 minutes into it, and then at the end. All right, it's through, and it beeped about at 300. So I'm going to do volume infused. I'm going to clear my pump with this one. Volume infused, and it'll tell me, I think I'm just going to go on and do my volume infused on that pump too, and be through with that. So do your A pump, do your B pump. That was where my antibiotic was, because it's pretty near 1 to 2 o'clock in the afternoon. So clear them, put it back on main screen, and I'm going to drop this rate down to 30 again, because you remember I have another unit of blood. So primary infusion, I'm going to make 30. Volume to be infused, 30. Stop. And I'm going to clamp my blood and open my saline. And think about it, because if you clamp one and the other, the fluid will go up into the empty blood bag. So you have to talk to yourself. Now, wait a minute. If I clamp this one, just talk to you. It's simple, but you just can't get in a hurry. And it's not going to kill them. It's not going to kill them. It's just makes your saline red and embarrassing. So now, order your second unit. So this get up this tubing can go through 2 units. I can use the same one for 2 units, and I think that's on there. And now, if they wanted 4 units, which sometimes they do, I've got to throw it all away after my 2nd unit and start another whole set. I could maybe use my saline bag, but. All right, so we got it going 30-30, we cleared the pump. My next unit comes, and when it comes, here it is. We check it again with a licensed person. And I'm going to hang it up, twist, take my old blood bag down, flip it over so it doesn't drip all over us, take it off, put it in a red biohazard bag, and now take the spike and spike my new. I'm going to repeat everything. The only difference is my tubing is red now. And so I still want to put, remember, 200 rate, volume to be infused 20 for the length of the tubing. But I've really got to let it trust my pump because the whole tubing's red. And I don't know when this blood stopped and started. I thought you ran some saline. I did, but it doesn't make it clear. It just goes through and kind of takes some of the blood, but it doesn't clear out your tubing. So I've got it. I'm doing my scribing of my unit, the time, the number on the unit, because I checked it with a licensed person. And it's going now at 200 an hour. That saline's going in that I was flushing at 30-30. Volume to be infused 20. And now I'm ready to hang it. So I hang it, spike it. Remember, I clamped your blood and let the saline run. When I spike it, come over here and clamp saline, open the blood, and start your 60, 300. And then in 15 minutes, of course you vitalized, but in 15 minutes, boot it to 150 up to 180. One day a patient said to me, I just came in for a transfusion. Put it at 200. That's what they do at the Rudy Center, 200. Well, I said, are you sure? Yeah, they run it 200 all the time at the Rudy Center. Well, I did, and the floor went crazy. They thought that was too fast. I said, well, he says they do it at Rudy. They said, well, we're uncomfortable. So we dropped it down. So I never go more than 180 just because it upsets my floor. But, so I'm just saying, it can go high if they're used to having it rate high. Volume to be infused, 300 if it's cells. Of course, you can make it 350, but you may not have that many cells. Usually if it's 250 to 350, 300 is a good time. Then increase it. All right. Questions about giving blood, or I should say packed red cells. The difference is whole blood. There's no difference if we gave whole blood, but the emergency areas are where usually it's given, and it's given as fast as you can in the emergency room and the OR. So they're not so particular about their 4 hours. They'll give it in an hour. Like I said, if they're fearful on the units that you're going to be overloaded, then they'll want Lasix pushed between the two so that some of the fluid comes off. Now, I want to, if you'll stop there, now we've talked about whole blood, we've talked about red blood cells, and now I want to talk about platelets, and it's still on, is it on page, where do you, maybe the next page, yeah. Page 6 in the briefs on platelets. Now, here's the deal, and I'll talk more about it when we talk about hematology, or you've got the YouTube for hematology, but I've already told you we have the red cells, the white cells, and the platelets for blood. Then we have plasma that aren't cells, they're just the plasma. So we've already talked about getting red cells into the body, or the whole blood, getting plasma and cells. But sometimes we just need platelets. And when, I don't know what your briefs say, but you know that we want 100,000 to 450,000 platelets in our body. If they drop down to 50,000, we're at risk for bleeding. If they drop down to 20,000, spontaneous bleeding. That's not good, because you can just be sitting here listening to me. If you've got 20,000 platelets, poof, you rupture and bleed to death. So at 10,000, nobody says anything to anybody. They are going to transfuse platelets if they drop to 10,000. And a lot of times they might at 20,000, but definitely at 10,000 they'll transfuse. So the platelets come, and I'm just going to say they come as, I thought I had more than this. Okay, now here I'm starting over. So the unit of blood, you and I have, a unit's 500 milliliters. We've already talked about that. That's almost a pint, or it's a little over a pint. So 500 is a pint. 1,000 is a quart in our thinking. So 500 is whole blood. I've already told you 250 to 350 is red cells in there. In that whole blood, 250 to 350 were red cells. 50 are platelets. And so that's what we've got to transfuse is the platelets, because we need some clotting help. So the rule is that you never give less than 5 50s. So it may come, if all the physician says transfuse, sometimes they say 1 unit, which usually means 5. Transfuse a unit of platelets, then we can already tell you it's going to be about 250, because a unit is 5 50s. If it comes in 1 bag, it's probably single donor. Single donor, because they don't need to mix if it's random donor. If they come in the little 50 milliliter bags, 50, 50, 50, 50, it's random donor. And the physician would rather have single donor rather than 5 different kinds. But if somebody's platelets are 10,000 and they're going to bleed in their brain, they want to just get some platelets in them. The bad news is that transfused platelets only live 24 hours. Yours and mine live about 10 days, I think it is. But if we're scared you're going to throw a bleed, then every hour is important. Now, your platelets arrived, they're yellow, and they came in 2 bags, this same size. I thought I had 2 bags here to show you. It doesn't matter, you can visualize 2 bags. But they're attached, the 2 bags, like this. And here's another bag. This holds 3, that holds 2, or 3 and 2, but it's still 5, because that's the unit that we give. Some people unclamp and drain into 1 and then clamp it and give 1 with all 5. You do not need to do it. If you ever remember siphoning anything, gasoline or whatever, unclamp the joining, hang it, spike it, and it siphons over. So it's just a you want to hold and drain, that's all right, but you don't have to because it'll siphon. So that would again be single donor. So we've talked about 5 little 50s, random donor, single donor. So let's say, now the bad thing, you kind of groan if the 5 come up because they all have a different number because they were all from a different person, and it just keeps you writing down identification, when they hung, when they were through. Because if you read in those areas, platelets are given as fast as you can. That's their rule. Where we had, we wanted our red blood cells, well, if it's whole blood and in an emergency situation, we want them to go fast. But on the unit, we say don't take longer than 4 hours. Well, platelets, you open it up and let it roar. I've never had a patient, well, see, they don't have white cells in them, and white is what fights. And it's platelets, it's not white. And so it shouldn't fight us. Now, one man told me, well, I've had one patient in 52 years that said he was allergic, that we really need to keep his platelets slow. I did because he told us. He said, you'll need to because I have reaction. Well, he knows himself. But I've never seen anybody react to platelets being given fast as you can. The other rule with platelets is never through a needle. It can be through an inner calf, and I might add, it can be given through the Huber needle or the right access needle. I don't know whether you can see that on the video, but it's a right-hand needle that goes in the portacalf. You say, well, that's a needle, because it is. But I ask about that because I'd always heard the rule. I'd heard the rule, never through a needle, because they clog. And I was told it's Teflon inside, so that it doesn't clog. So, fast as you can, never through a needle, and you really don't have any problem with it that way. So, these platelets came up, here are all 5, and they don't come with their own tubing. But let me tell you, you may work in a hospital. We used to have our own tubing for platelets, and it looks kind of, it looks like blood tubing. It's got a filter, and so it's kind of like that with one spike. You spike it and give them fast as you can. Just make sure that saline is stopped or whatever, or you flushed with saline and then put them in. But they go fast, and they've got their own tubing. That may be. And I think this is smart. This hospital said we're throwing away too much tubing because we're not using it fast enough, platelet tubing. So I think this is real smart. They said, just hang it with your Y blood tubing. And if you want to clamp off the side for saline, you can. And you can spike your platelets, run them down here, run them to the end, and put them in your port. Put them in a port and let them run. And I think that's clever because we'll have this kind of tubing around all the time. My floor, certain nurses want us to go in and put saline over here and flush it with saline and back it up. I'm not sure I even need this. I keep turning it off, but I think I can just talk it. I do it, if the nurse doesn't care, I just soon not waste saline because I can just hang this, puncture my platelet bag, open. Of course, I clamped my tubing, remember? When I opened my tubing, I clamped it. I clamped and clamped. I spiked gloves. Of course, I'm wearing gloves because it's a blood product. I spiked my, let me do it. hold it, spike it, open, squeeze. Again, get it up here so it doesn't hit plastic. You know, you want to make sure it isn't even tilted where it's hitting plastic. So make sure it's going straight, not in saline, but in its own platelets. And then run it to the end with dignity, clamp, clamp, and then attach it fast as you can. It doesn't, really, we don't put them in a pump. And don't be surprised, I don't think you'll have the problem, but for a while some hospitals didn't want us to pump blood because they said that rolling action of pumping bruised the red cells or bruised cells. They say now it's soft and it doesn't bruise them. I don't know. We do pump blood. We don't pump platelets because we do them so fast. That's platelets. How much is it going to up us? Because we've talked about 2 units of red cells will boost our hematocrit 10, 5 each. The data says that if you do 5 50s of platelets, which is what you'll do, sometimes we do 10. And we use, I think, the same tubing for 10. I think you can do it for 2 sets. They say the word is 12 to 15,000 per 50. When I teach generic students, I just say, remember 10, it's easier, 50,000. So if I have 10,000 platelets, I hope this 5 shoots me up to 60,000, and I'm past high risk for bleeding, because 60,000 gets me over that 50,000. So 12 to 15,000 is what literature says. It's just easy to remember 10,000. That's what it's going to boost me up. So that's why some physicians want 10 50s and boost it up even more. Plasma. So platelets are platelets, red and white. Now, you know, I've spoken to the red, I've spoken to the whole blood, I've spoken to platelets. I haven't spoken to transfusions of white. Let me say I've never transfused white. I don't know, I've never in a hospital heard of transfusing white. I read about it. Some hospitals even say at the end of the hall there's a room you can go to get transfusions of white. And you sit in a recliner, and somebody, this is kind of interesting, they access your vein, they access a donor, the donor gives his blood, it's centrifuged, and then the white goes into the recipient. And the other blood that's not white can go back to the patient or be used for other purposes. The most interesting thing about that is that if you give white, you don't miss them, because white cells, the body recognizes that there's a problem. And what do white do? They come out when there's a problem, and they start multiplying. Before you finish the transfusion, you have more white than when you started. Isn't that fascinating? I know, it's just fascinating. Like I said, I'm already telling you more than I even know, because I've never transfused white. I just know New England or someplace they do. What we do have is your sub-Q that we've mentioned that will stimulate bone marrow to make white. And why don't we go on and keep all your papers out, but go to medication and look for Numega under medication in your briefs. Numega, N-E-U, Mega. And what page are medicines? 16, So it's gonna be 17 or 18 in your briefs.
20,
What page?
page 20.
Page 20. And is it New Mega that is for increasing platelets? And you get the sub-Q, page 20 in here, in the briefs. It's sub-Q, they're expensive. These sub-Qs that boost our cells cost $500 to $600 a shot. And they're given sub-Q and they stimulate the bone marrow to produce. That we give a lot, that ups white cells. Now go on and look at Procrit or Epigen. Do you see those there? Epigen, Procrit, you see that on TV. Those boost red cells. Are you finding it? Epigen, EPI, or Procrit.
Epigen is on 18.
What page?
18.
18. Which one is there?
Epigen.
Epigen. Do they call
AK.
it Procrit?
And then they say AK. Procrit.
AKA Procrit. And that's the sub-Q that will boost red, that you may not need a transfusion if you can get that. And then white, I'm sorry, New Mega was platelets. White, New Mega was platelets. White is, wait a minute, growth stimulating colony, what's it on there?
Nubigen.
Nubigen, NU, and it's also called the growth stimulating factor hormone. And it will increase white cells. I may have told you wrong a minute ago. Omega stimulates for platelets. Maybe I said that. And Nubigen, or G, growth stimulating, makes white cells. Produced from the bone marrow. See, they're all from the bone marrow. Now, when I told you that, now go back to where we were. The three cells, and we just finished with talking about white, plasma. We've got, why do you get plasma? If you'll go to your hematology tape on YouTube, it tells you plasma does, I think, 5 things, maybe 4. It is 98% water. This is plasma. 98% water. It's gamma globulin, which are antibodies. So we've got our antibodies. And then it is albumin. Remember albumin, the largest protein we've got? The blood has it already for us. And the 4th one is fibrinogen. And you remember fibrinogen deals with clotting. We can't clot if we don't have some fibrinogen, and that's in our plasma. A favorite test question I ask is, when I teach generics, why does a patient most often get plasma? Well, they don't need it for water. They don't really need it for gamma globulin, because we can give gamma globulin. They don't need it for albumin. Albumin I can give just like this in a glass bottle. So it must be for fibrinogen, which is usually the reason. I mean, that mostly is the reason. Sometimes plasma is given for blood volume, just to give some, it's real good volume. And it stays in the system longer. You know, D5W is out of our vascular system in 3 minutes. D10W is out of our vascular system, did I say 3 minutes? 10 minutes for D10. Or lactate, our normal saline stays, I think, 10 minutes. So sometimes plasma is given just to stay in our blood system and give us some volume. So our blood pressure, it doesn't tank on us. So fibrinogen is usually the reason we're going to get plasma. Okay, the physician ordered plasma and usually says 1 unit of plasma, and that's about 250. So that unit of blood that was 500, 250 was cells, red cells, 50 was platelets, so another 250 is probably plasma. So it comes usually in one bag, and it's yellow, and it'll say plasma, and it's 250, and hopefully the match is good enough, and it's done the same way the platelets were. In this hospital, again, if you have plasma tubing, so be it. That's easy, just spike it. It does not need all the Y apparatus. Here we do, because it does need a filter. You can't just do it on any tubing, but you can do it on blood tubing and clamp your saline side, because it does not have to go. Let me tell you this one thing I do like to do. Not all the nurses do. They say it contaminates. It doesn't. If I didn't flush it with saline, I didn't put saline up. Remember? I just clamped it, kept the cap on, and I just put my platelets and my plasma just straight in. You know, I did my filter and all that. Well, what I like to do when it's finally gone empty by gravity, I like to turn it over so it doesn't drip on me, and then just run it in. Now, one of the nurses said, well, it's contaminated with air. I'm going to stop it when it gets right at me, so no germs are going to go in, and then stop it when it reaches right there. Just clamp, take it away, and they got all the platelets, because that's 20 milliliters of platelets, or plasma. Okay, that is plasma, and it's just like the platelets. I do want to mention albumin, though, and it always comes in a bottle. There was a resident one time we were giving, he was aspirating it out. Well, he asked that we aspirate this and give it, put it in a bag. And I asked him why. And he told somebody, he said, she won't let me pull it out and give it. Well, it doesn't need to be. There's a reason it's in glass. It's not to be, it clings to plastic. So it's always given in a bottle. Now, the thing I want you to remember about bags and bottles, a bag, gravity pushes. Now, the pump's helping us, but gravity's also pushing. And so, I want you to notice that this disc, well, here, it opens. You can see a little thing open and close. It's interchangeable with glass or collapsible, flexible bags. So, you notice when we did this earlier, I didn't talk about opening things, because gravity helps me. But a bottle, gravity can't help me, because gravity can't push on glass. So that's where, if I use this tubing with albumin, I have to open the little side door, because there's a filter there, and air out here goes up into the glass bottle and pushes the fluid down. So it's an interchangeable, but make sure it's open for glass and closed for bags, because the gravity goes up into here and pushes on the fluid, because it can't push on the bag. So it's just a good thing to keep in mind, because I've heard people ranting and raving, just a bad bid, the hospital bought something cheap. Well, you didn't know you open. So albumin does come in bottles, and I'm pretty sure we just use regular tubing. Now, to ease into auto infusion, and it's called all kinds of things, auto infusion is. Listen, auto yourself is infusing yourself. And somebody had the bright idea that if a surgery is not dirty, why don't we save the blood that bleeds out and give it back to them if it's clean? And so that's auto infusion. And you find that it's in the briefs. Look at 5. I think it's on 6. Is it on 6? Page 6 of the briefs. You'll see your auto infusion. Now, all right. So here we are. You get a incision, straight line incision. We'll say abdominal, and they open you up. They clean out whatever, bring an organ out or a tumor, and then they sew you back up. And they sew nicely, but you know yourself, fluid escaped interstitially, and I'm swollen a little bit. Maybe not a lot, but a little bit. Somebody, a surgeon, thought, why not stick a porous tube in that swollen area with suction, and it'll take that interstitial fluid and tighten it back down, and they'll heal quicker. And that was such a clever idea, and they did it with the Jackson Pratt and the Hemovac. Remember? Mm-hmm. That's your porous tube. Make their suction, and now the suction, you know that you never have them more than a day or two, because it took just the surrounding area and tightened it up, and it heals quicker. So that's what the physician does. It's a preference of the physician of whether to use the Hemovac or the Jackson Pratt. You know they do both the same thing. And I don't have the cord on the Jackson Pratt, but it's on the porous. It's the same thing. Just always keep them deflated. They're of no use, and you empty them all during the day. There's nothing magical about the 8-hour term. It's doing no good unless it's deflated. And that's where you're helping it heal quicker. And that's where, I have to add this for Dr. Dudley's sake. Dr. Dudley's one of our physicians, and I may have already told you, so just humor me. This is sometimes sewn into the wound. Sometimes it's just laid in there, and they suture around it, and just there, and when it's time to take it out, you just bring it out. Well, Dr. Dudley, let's face it, that's not real high tech to clip even if it's sewn in, you just clip a suture and bring it out. Have them take a breath and hold it and bring it out, so they're thinking about breathing and not what you're doing. And so Dr. Dudley one day wrote, have my resident DC the Jackson Pratt, doing the same thing. Hey, we do that all the time. Why did Dr. Dudley want his resident? Does the resident need that? I get it if he thinks the resident needed to do it. So when I saw him, I said, Dr. Dudley, of course we'll do what you want, but my students can DC the Jackson Pratt. He's just real mindful, thoughtful. I thought, well, you know, that wasn't a hard question. And he's so thoughtful about it. And he said, okay, if you promise me one thing. I said, what? He said, that you release the suction before you take it out. And I said, well, now I do, but talk to me. He said, and it makes such sense. He said, it's usually 2 to 3 days before we DC them. It has begun to heal. If you pull it out and the suction, it's going to ruin my healing. Doesn't that make good sense? Yes. And so he was hesitant to let us if we were going to jerk it out with suction still on. So I just share that because I haven't pushed it that much. I just knew that's what we usually did, but I didn't think why. And it makes such sense that he says it tears up that whole buildup of tissue by pulling. So I thought that was a good point. All right, this particular physician is going to have surgery and knows that they want this kind of thing. a Jackson Pratt, but knows it's pretty bloody, knows it's going to be it's a pretty vascular, and so what they do is put in that porous tubing, like we said for the Jackson Pratt or the Hemovac, but they have it attached to an auto infusion. It's the same thing as the Hemovac, and this also, if you've ever been around a GISH, G-I-S-H, there's loads of different varieties of the auto infusion. This is just an easy one, and it's so visual that I just keep showing this one. I think it was one of the first kind that came out. But it had the tubing porous into the area, and they come to you on the unit or in the recovery room or wherever, and the report, they're lower than the wound, and the report is, I started it at 1:30, and it probably written on here someplace they wrote 1:30. Well, no, the surgery. He put this in surgery. Now it's all yours, and there's on page 6 gives you an idea. So this should never be out of the body longer than 6 hours because of contamination. So you say to yourself, now remember it's his, so we don't need a fluid overload. They've been in surgery. We're not going to overload them. So you say to yourself, okay, he came out of surgery at 1:30. It's 3:30 now. 2:30, 3:30. I've got a while, and I can see, even though hard container, we always need to read through a hard container. This is hard, but it's got a bag in there, so it's not real accurate. But I'm going to go another hour or two. I may even go, it's been 1:30, 2:33. It's been 2 hours. I've got 3 hours. I think I'll go at least another hour and get some more in here. So, and it's my choice. So, that's what I'm going to do. But it means I'm going to infuse him with his blood. So, let's say an hour and a half's passed. So it's now been 3.5 hours. So I go to the supply cabinet and I get another apparatus. Now I'm not going to change the porous end, but it has an attachment, and so I'm going to clamp. I always love to clamp before I take something off. So I'm going to clamp the auto infusion and attach a new reciprocal and take this old one, and it's now my blood bag. And now I'm going to treat it just like I did when we gave blood. Only I don't have to do 15 minutes. I've been puddling here and piddling. I've just got an hour because it's been 5 hours since surgery. So I've got an hour to give. It looks like it's about 300. That's fine. I will put it with my blood set. I'm going to do saline. I do it just like I did with the blood. Saline on one side, spike it on the other, but I don't need to check it with anybody because it's theirs. Spike it. I already primed my tubing with saline, just like I did with blood. It's now hanging, but all those rules of, oh, you can get vital signs, of course, but you don't have to go slow at first. It's them. You put it in at 300 an hour if you want to. They just lost blood. They just lost 300. So speed is your choice. I have another one collecting, and my tubing will last through 2 of them. And if it's under 150 that I'm collecting, they say don't mess with it. Now, if this first one had just been 150, I would have gone to the supply closet and gotten a Hemovac and replaced my auto infusion with a Hemovac. Just clamp, attach, and this is attached to it instead of the auto infusion. And you just do it at its junction, not at the porous area. Porous stays in the patient. So I'll give it fast as I can on the other pump. Maybe stop that because of saline. and blood if I'm not running saline. So that's auto infusion. We used to put anticoagulant in it. And then they realized it's serous, it's blood, it's serous material, and it doesn't clot. So they quit having us put heparin in them. And so now, this ran in an hour, because I made it run in an hour. And now, this one's collecting. This has just been going an hour. Our new one. It's slow. It's not that much, because remember, it just is taking what's around. So, I'm gonna take it right to 4.5 hours. No, 5.5. Because I'm gonna use this same, I'm not getting new tubing. And let me give him all he's got. So I go to the supply cabinet, I get a Hemovac, because I'm not going to do another one. And I chose to hook up this Hemovac instead of another auto infusion. Take my bag after 5.5 hours. Hang it back up to the same set, throw away my old, spike it, give it in 30 minutes. A wonderful, wonderful mechanism for replacing. And of course, it's a physician's choice to do that. Now, I think that's what I want to say. Any questions on platelets, plasma, blood, red cells? I think that, and albumin. Now, I want to talk about I want to talk about drawing blood from the central line, or the different lines. You've got your page 30, what there?
31.
Yeah, that one over there. Is that 31? Page 31 in the agenda lists all the central lines. Now, before we go today, we will go over peripheral, which is also on your tapes to review, and it's my way of doing a peripheral. So just understand, it's not the only way. But if it's central, some IV therapists who are registered nurses do them. I've never done central lines and don't care to do them, but and I don't care you to learn them all that are on page 31 of your agenda, but I would love for you to know know somewhat difference in them. So the granddaddy of all, who's been around longer than I have, are the subclavian, and it's usually 3 ports, and somebody put it in central, and it has an opening at the tip end, halfway up, and a little higher up. Each port opens at a different spot. They don't all gather at the bottom of the catheter. I think I may have told you, but I'm going to repeat it. It was, I think, a student that said red, white, and blue. They're all alike. They do open at different places, but red is not for blood, white is not for TPN, and this isn't for saline. A lot of people think that. Doesn't matter. If you want to do that, that's fine. I like what they taught me, red, white, and blue, if only one's being used. If none are being used, and I'm just flushing, just to keep them patent, and I start visiting with the family, and I had started, I can't remember which one I just did. If I knew I just did one, I know it's red. So I like to always do the red, white, and blue. If red is in operation, and I need to give a medicine, or I need to give something, and I wipe off, I know I'll do white, because that's second, red, white, and blue. It's just an easy way to keep up, but it doesn't matter. So that's your granddaddy of all. And then when I pass it, push your pen in the spring, because we don't cap them. The spring in the middle closes it, just as pushing with our tubing seals it. So I'm going to pass that. That's the granddaddy of all. Then let me do, I guess, pick. I'm not doing them in order, but the pick, if it's purple, a lot of times they call it the power pick, which means they don't need another IV for dyes and things, media downstairs in the x-ray department. But this will be the pick, percutaneous, peripheral percutaneous inner catheter or something, PICC, central catheter. And it's put in peripherally, but it's central. And so it's on the peripheral area. It's put in by nurses or physicians, but the nurses have to be very trained. The pick, the rules on it, not that you have to memorize them. If you were home healthing or private dutying a pick, you need to Google it and read it. You can see it's small, lumen. It has a rule to never, if you're going to draw blood from it, or give medicine straight in it, you always use a 10 milliliter syringe or bigger, because I think it's an old-timey rule, but we'll keep doing it. When they first came out, they were so soft and they were so porous, you could almost puncture them. And I think, so they said, the smaller the syringe, the more power. So if you have a weak spot, it's going to blow it out, and they're going to, the chemo or whatever is going to eat up that tissue. So they made a rule, only a 10 or bigger, because the power isn't as much. So that's one rule with the pick, is only push a 10 milliliter syringe, whatever's in there. If it's 1 milliliter, do it in a 10 milliliter syringe. Now, if they've got an IV going, you can do it on the port, the side port that we're talking about. Your side port, you don't have to use a 10, because it's just the fluid's going. For whatever reason, the power isn't going to be that much. It's just more powerful if you're straight in doing it. But if it's a port on the side, you don't have to use it. So the pick, a 10 milliliter syringe, and if I draw blood, in most hospitals, labs draw blood unless they have a central line. If they have a central line, they want nurses to do that so they don't have to stick them again. So we need to draw blood on this person for some tests. Never use a vacutainer for the same reason of the 10 milliliter. They think the suction, when you put the vacutainer on, the suction is too much. So they want us to use those, and you know, that's how we draw blood from a central line, is put a vacutainer on it and then just push to get your specimen. But it's too powerful, and they say it'll blow out a weak spot, that suction. So what do? We draw with the 10 milliliter syringes. The next page in your agenda, I think, yes, the next page, 33, I guess, tells drawing blood from the central line, and the next page is drawing it from the central line, and it's hard to read it, but any specimen you get other than TPN, total parenteral nutrition, and let's say our, here we are. We've got TPN going. We've got a regular IV with antibiotics going. And so we need to draw blood. Well, I'll use this empty one. That's what I'm going to use. And I can use my vacutainer because this is in the central line. So I put my vacutainer on, turn off all pumps. That's our biggest thing. Turn off the pumps while we can draw blood. I'm not getting it from one that I'm drawing, that I'm giving. I don't care, it'll suck it back up there. So all pumps are turned off. And you discard 5 milliliters. If you use a test tube, usually the size is 5. Just get it. When it quits filling, that's your discard. Now you need your specimen. And then they have a rule, and I don't know whether I have it written there. When you get through, do it 8 times up and down. You don't really have to do it to all of them, but rather than try to remember, is this the one I do 8? It's just easier. The blood bank says just do them all 8 times. And that way you don't have to remember which you rotate 8 times and which you don't. If you're, let's say this is TPN, and then this is our regular IV, then I want to just stop them all and draw up 10 discard, because it's a lot of TPN is high in sugar. So 10, throw it away, now get your specimen. And then when I'm through, flush it with a saline just to flush all that back down. So that's drawing blood from the central line. So we've talked about the subclavian. I talked about the PIC. Now I want the Hickman in the home. Hickman in the home are white silicone. And there's just this white color. The only big thing to remember about them is that tape eats them up. You don't put tape. You can use opsite, but not tape. So tape the IV tubing that's right here coming out of it. You can tape that, but you use that opsite or occlusive dressing, but it eats it up. They're alike in that the material. And see, I trust that you would be, if you took care of somebody with one of these central lines, you're going to Google how to take care of it, because there's no reason for you to memorize all the data on it. But what I want to tell you, a home is right here. It may have 2 or 3 ports, and again, it's really treated very similar to the old-fashioned first kind type. The only thing is we don't put tape on it, but and everything stands for the same. The Hickman looks that way, but it's longer. See how long this is? And it's very clever, but I wish I could tell you they had a great idea. It was a great idea, but I don't think it's proven anything. People, because their central line was up here, if it stayed long, they were getting infection. Well, they checked with urine, no urine infection. It has to be up here, but they can't really tell unless they take it out and run the tip for culture and sensitivity. So we were pulling them. They'd have to put another one in. We saved the tip and sent it to the lab, and it might be infected or maybe not. The trouble was, it's so easy to get infected up here, especially if you don't take precautions. In the hospitals, they are so intent on not having central line infections. Well, it's a good thing because it's right there at the heart, and we don't need any pericarditis or anything. Well, somebody had the clever idea, we're getting the infection because it's right here. why don't we have the opening way away from the superior vena cava? And that's where the Hickman was born. They put it in with a trocar, with this in the middle. They go through fascia, and when they get to the superior vena cava, under the tissue, then they thread it, nick the vein, and thread this in the vein. But the entry is way down here. I think it's a clever, great idea. But I'd like to tell you that everybody now has Hickmans, but they don't. The stats must not have been proven, because I don't see many Hickmans really. And that was the reason for the Hickman. That's the reason it's so long, is they were putting it in down here. And I still see Hickmans, but not, you would think everybody had a Hickman to keep cut down infection. But they came up then with the better portacath, which is even better. So the Hickman in the home have silicone. Hickman's longer because it's put in a different place. Now, the portacath, or what do they call it? Portable cath, or peripheral IV, implanted port. That's what your data calls it, the implanted port. It's put in, I'm going to pass it, with the Huber or the access deal. I'm getting ready to tell you, if you've never done it, and tomorrow or this afternoon, if you ran into somebody that said, can you put a portacath in a portable central line? Yeah, I think I can, because I think you can. I'm getting ready to tell you how to do it. It's easier than starting an IV. They come with, this one has blunt because it's been used and the mechanism closes sharp so we don't stick ourselves. But these are the Huber needles, access catheters. And now here's the way you do it. Somebody, usually you're on chemo that you get a portacath. You can just have bad veins and a lot of antibiotics and get some of the other central lines. But to get the portable access, you usually are getting chemo. So a physician takes, and this is still stainless steel mostly. You see it's just a disc that, I'll pass it around. And the physician cuts, puts it in, then attaches this to the superior vena cava, and then sews you back up. And there you are, you've got it. They put some fluid and then do an x-ray to see if it's patent and we can use it. And were you with us when we got permission to use it Wednesday? What was put in and they sent word we finally could use it. And so here's where I'm telling you. It's 2 in the morning and somebody's asking, does anybody know how to access a portacath? I want you to say, I think I can. And you just go up with the most confidence and say, what size access needle do you use? And they may say, I use 1 inch or 1.5 inches. And it really doesn't matter, it's just going to be higher up if it's 1.5 inches. But so that's in the patient. And so I'll ask them, what size? Well, I use 1/2 inch. This one's so small. Go on and get you a syringe with saline and flush your access or Huber needle. Of course, it's got a covering. Put that over there. Where is your access? It's on the left. Now you feel, and you can feel it, especially in the emergency rooms. They come in and they start an IV and they say, I've got a portacath. Oh, okay. So feel, you can feel that disc. So put your gloves on. Take your Huber needle butterfly part. Put your 2 fingers on each side through them, and put this right in the middle, and just go straight in. Doesn't hurt, it hurts a little bit right there, but it hits the back. So there's no wrong place to put it. That's why I say it's easier than a peripheral. Push it to the very back, aspirate, you've got blood, because that's attached. So you have accessed it. Can't you do it now? Isn't it easy as pie? And so go on and put the occlusive. They can stay, they like to change the needle about every 7 days. So that's all you do. And it's that easy for the portable cath or PAC, portable access catheter, implanted port, whatever. Sometimes I've asked students, if it's, I'm about to forget, if the portacath is here, it's called portacath. If it's here, it has another name and it slipped me. But it is the same. They just call it something else. But so sometimes you may, when you assess a patient, you need to see, he's got an IV in his arm. A, is it peripheral? B, is it a PIC, peripherally inserted? Is it a passport? That's the name. It's portacath here, but if a portacath, and sometimes they're put here, if it's a portacath, it's called a passport sometimes, if it's in the arm. So you have to examine it and feel it. Oh, I feel a disc. It must be a passport, which is a portacath. Now, did I cover them all? Maybe vas cath, I did. Peripheral dialysis catheter. Yeah, I just want to say the dialysis catheter, very tough, and it can be put in the brachial area. I see them all up here. They're very territorial. Dialysis are. They don't like much for us to use them, but we can, because it's a central line, and I've used them before, but they don't much like for us to get into their territory. But it is used for the dialysis artery and vein. Was that all of the central lines? It was, wasn't it?
Yes, sir.
Now, I just want to just review the stopcocks. Stopcock to me is such a simple thing, and it makes such sense. I want them back, but pass them. And just remember, pass some down. They're the same thing. I just take one, and here's the rule. It's an insert into IV tubing. So it's an insert. This goes to the bag, this goes to the patient. Wherever the main gear is pointed, it's clamped. So if I have it clamped, let me put it up with the cap on top. Now that's your best way, because I've got to give some medicine to this patient. So I take the cap off. Nothing's going to be spurting out because, oh, yes it is. My clamp needs to be up when I take the cap off. That means it's clamped up. So nothing's pouring out. I've got IV running, but it's not coming up. And I'm going to give my medicine. I don't know what happened to my eye. So I take my medicine and put it in that port. Well, it's not going to go until I change my gear. Do I want to changed my gear to my, oh no, because I want it, the bag flow to take the medicine in. Do I want to put it over toward the patient? No, because he's not going to get it. I drop that gear toward the floor because it's open this way and this way. And now I give my medicine. It's flowing with the IV. Now don't take it off until you put the clamp back, because then it's spurting out on you. And you have to just talk to yourself. So take it back, and it's clamped up. We had one of these on, I don't know, Tammy, if you saw it on the man with the tube feeding, and he had one of these on a tube feeding, and that way we would give him food, but you know, we wanted to clamp it when we put the food here, or the formula, put the formula, and then push it down till it goes in. So they can be on anything, but just so you know the gear, and you can send them back after you play. Now, I guess the main thing left is starting the IV. And so let me talk a little. Again, it's on the YouTube IV, but let's just review it again, knowing that it's my way, and you get to pick your way. On your briefs, I believe it is, it tells you the colors of your intercast and how much fluid they'll give you. Of course, the smallest is the 24. People think the average one is the pink, the 20 gauge. If you find that page, tell me and I'll announce it. I think it's in briefs. And the average one, look at IVs, it's probably in
Page
there.
12.
Huh?
Page 12.
Page 12 in the briefs. Have the different colors, do they, Sharon?
Oh,
It's
the colors.
13. Page 13 in the briefs. And it has the different colors.
Yeah.
Knowing that the yellow is the smallest lumen. Neonates have these in them. And y'all, it's almost embarrassing. When I was in school and after for many years, we were told if they're getting blood, they have to have the 20. And that was known. And then Vanderbilt is who supposedly did the check. Somebody, why nobody else came up all those years said, wait a minute, we're giving adult blood to a neonate, so why do we have to, we give adult blood to a neonate in a 24, why do we give adult blood and it has to be in a 20 for adults? And somebody said, that doesn't make good sense. Oh yeah, it doesn't make good sense. So Vanderbilt did a study, because the idea was the small lumen broke the red cells. A small 24 broke the red cells. But Vanderbilt did a study and said it's not the small lumen crowding in there that breaks red cells, it's the speed. If you push it in so fast, it'll break them. But letting them go slow, it won't break them up. So that's when we realized you do not have to give blood just in a 20. You can give it. Neonates have been doing it for how many years through a smaller one. Now, they don't give it fast. If you've ever been in an NICU, the blood's in a syringe with a rubber band, giving it real slow. And remembering the smaller the number, the larger the lumen. A 14, a 16 are huge lumens. Did I say it right? And the bigger the number, 24, is the smaller lumen. Only in IVs, when you get to catheters, it's what we think, a 12 small, a 20 and 18 are larger. So you decide they've been changing them to try to protect us from getting stuck, and pretty much we have different kinds, but pretty much we've got the kind that you have grippers on the side. You go in and you look for the blood to flash in between. I tell people go first and third finger. Don't do your index over the flashback area. So they've got grippers on the side for you to go first and third. Go kind of a right angle. A friend of mine's husband's a pilot, and she said, I just think about landing an airplane. You break the skin, and then you put the wheels down to the airplane. And the big thing is to hold it taut, because it'll just, just wrinkle up. So taut. I like to stick your hand in here. I learned to taunt it below where I'm going in. I wish I had learned to taunt it above. My hand wouldn't get in my way. I just hadn't changed, and I'm not going to change my way at this time and stage of the game. But the reason I'm not as crazy about taunting at the bottom is when I go in the right angle and I level, my finger's in my way. And so I have to get way back, where if I'm above it, I can taunt and nothing's in my way. So I go in at about a 45, put the wheels down, and the thing I'm watching are the vein and the flashback. My eyes are doing this the whole time. And I'm not seeing blood, so I'm not in the vein. So relax it and let it see where the vein, I'm on the side. So taunt it again and try your best to turn a little, but you can't go much or you'll go through the vein. So barely go, see blood. Now, just keep it taut, no rush. If I'm in a vein, is it still coming? And if it is, I'm good. If it just made a speck, I've probably gone through the vein. So if it's still filling, that's great. Just calm down, take your tourniquet off, take this finger and push the polyethylene tubing in. You can do it with this finger. It's just got to click. Now the needle is here and the polyethylene is in the patient. Now, I'm going to reuse it, so I turn it upside down. You can't, but reuse and reuse. Some people are inclined to push and pull out at the same time, and they end up with this out and this isn't in yet good. So don't do that. Try, if you're here and you start to push and it won't go, put it back and go with the whole thing just a little more. You may have been a valve there that you were up against. So come back out and go through the valve. The other thing I wanted to tell you, one of the best IV therapists I worked with said that, I think I told you, your veins kind of slow up 90% at night. So don't be discouraged if you can't get an IV in at night, because you might be able to in the morning. I think we talked about that because the cilia of your lungs stay busy all the time, but the veins kind of go to sleep at night. You turn that off, please, babe. Maybe months or maybe years, and you go back to the doctor, and maybe your dyspnea is not even present. You think you're doing fine, but you know doctors always look at your feet and ankles and notice a little swelling. Well, the heart is given more problem because now, even on the drugs, it's not bringing the fluid back from the extremities. The pump is just not good enough to pull it back. And then I think I talked last week about the drug Saline. Remember, on page, just to remind you, page 22, Saline enhances the diuretics. So the physician, at some point, not the first time you have edema, will increase your diuretic, increase your dig, and you'll try that a year or so. And then it's just getting so high and you're so dry, the physician gives the Saline. And so I've been over a little bit, but I wanted to emphasize it just a little more. Dyspnea, and then it goes to edema. And it's all because the heart is having trouble pumping. Now I want to do, let me talk just a little nutrition. And I sometimes hesitate to talk nutrition, and we'll take a little break. I sometimes hesitate to talk because everybody has their idea about nutrition, me included. And I'll get a little more on it when we talk diabetes. But I think it's so important to realize that fat has gotten a bad rap. And fat, we've got to have some fat in our diet to absorb the fat-soluble vitamins A, D, E, and K. And if you cut back fat, you can take all the multivitamins in the world. All right, I'm gonna pick up nutrition where we left off later. And so I want to continue now with
Now when you take it as well,
hepatitis.
when you've answered enough questions, it just shuts off. Remember years ago, you had to
Yeah,
wait
yeah.
like 8
No,
weeks to get
no,
results?
mine cut off once you answered enough correct.
Oh.
I think it was.
I took mine at 89 and you had to wait 6 weeks. You check the mail every day to see if you passed your boards or not, but
Yeah.
they don't have it like
No,
that.
it was right about that time, I think. When
Oh,
I
you're
took it,
lucky
that they
then,
were
'cause that was a
rolling it out.
nightmare. Wondering every day, did I pass?
I know it. All right, let's get back. Let me talk just a little bit on hepatitis. And first off, it's a virus, and it is transmitted, well, they say infectious, or hepatitis A, which is another name is infectious hepatitis. And that will conclude session 4 of this refresher course. Next time will be session 5.